Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and we will be interviewing this evening Dr. Michael Fine, a family physician who is an author, community organizer, and past director of the Rhode Island Department of Health. I'm joined also by Alyssa Smith, Allie Abel, medical student from Albany Medical College.
Great to be here, Larry. Thanks.
It's good to have you all with us.
Great to be here. Great to be with you, both.
So, Allie, can I ask you to begin our interview?
Of course. So, Dr. Fine, thanks for speaking with us. I was wondering, could you give us a little background about yourself, particularly where you're from and maybe what inspired you to become a family physician?
Sure. I was born in the Bronx and I grew up in suburban New Jersey. I come from a family of immigrants. All my grandparents were immigrants. They all came from the same part of Russia, Poland. And there were no physicians in my family ever, as far as I know. And I think what inspired me to become a physician and a family physician was a particular passion for communities. I think human life really and human meaning happens in and around communities. I came from a small community, and I'm sort of used to, or always got used to, seeing life from the perspective of other people. And it occurred to me that first there were no physicians in my family, and we needed somebody who could, sort of take care of us if people got sick. And we didn't have that. And I had a perception that the medical establishment, the medical world, was kind of foreign and self-serving. And I wanted to make sure that there was someone who could protect everybody in the family. Thankfully, now a couple of more people have gone to medical school, so I don't have to carry that by myself. And the other thing that I think drove me was this ethic that came from my grandparents, which was that it's unethical to profit from the misfortunes of others. And I kind of saw family medicine as the way to be with and for communities and to make sure that no one was using health and healthcare to profit on anybody's back. I think those two things together were kind of the driving forces.
So did you stumble upon family medicine when you were in medical school, or when did you first find out about family medicine existing?
I first found out about family medicine when I worked as a community organizer in the South Bronx on 167th Street and 3rd Avenue in 1977 and 78. And as that was a part of the Bronx in those years that had been devastated by community change. It had been abandoned by the community that my grandparents were from, that had lived there for 60 or 70 years. They had moved to New Jersey or Westchester County, or to a part of the Bronx where it was called Co-op City, where they had built a bunch of co-ops. And their generation of Eastern European Jews had been replaced by Latinos, mostly Puerto Ricans, and African Americans. And in the process, the community infrastructure had been, there hadn't been a smooth transition. That community change happened effectively overnight. And when it happened, landlords abandoned their buildings. Many of the old brick apartment buildings in that part of the Bronx burned down. And there was kind of social devastation. There was some high-rise public housing, but they were not places that in general were thought of as, warm and hospitable. The elevators didn't work. There was danger in the hallways and so forth. So I went as a community organizer as part of VISTA and part of a sweat equity housing group that was trying to rebuild a sense of community and neighborhood kind of from the ground up, that organized tenants and buildings, that did the renovation of buildings and trained people in the trades. And I was brought on to try to figure out this healthcare thing. So I had no background in it because there were no doctors in that neighborhood. There were no pharmacies. There was nothing. And so I was sort of given freedom to do whatever the heck I wanted around healthcare, because nobody had any idea about what was happening other than everybody knew that the people in these buildings they were organizing needed something. They needed some access to medical care. And everybody felt like there was none. And so I got to work to try to figure out what to do. And as part of that process, first, I discovered that only a few blocks away, even though we had this perception of zero healthcare, maybe 10 blocks away or 15 blocks away, was Martin Luther King Health Center, which was really then the flagship of the community health center movement in New York City, really the first big community health center built in New York. And then I somehow learned that that health center was staffed by residency programs from Montefiore Hospital. And I didn't even know what a residency program was, but, gradually figured that out. And I learned over time that there was this whole part of residency training at Montefiore called the Residency Program in Social Medicine, which was pretty much created by Dr. Vic Seidel. And that residency program in social medicine had 3 subspecialties or specialties in it, if that's what you want to call them. There was internal medicine, there was pediatrics, and there was family medicine. And so that was how I figured out there was this thing called family medicine. And it got even more interesting because one of the people who was in residency training turned out to be somebody I grew up with, who I hadn't talked to in years. His name is Neil Kalman, and we have followed kind of similar career paths, though he's much better at all this than I am. But having him to talk to was also interesting, and he was a family physician. Long answer to a short question.
Wow, no, that's great. And then, so you had your medical education and residency in the Bronx, and then what happened? Now you're in Rhode Island. No?
I didn't stay in the Bronx.
Okay.
I ended up coming to do medical school at Case. Einstein, where I had hoped to go, didn't take me until the very last minute off the waiting list. And by then I was accepted at Case and decided to go to Case, which was a pretty good medical school. And in a way, it was kind of a heartbreak to be pulled out of this place where I had worked and where I knew all these people. It's probably good for me at the end of the day, because I think my life would have been quite challenging trying to continue to do organizing work in the Bronx while I was in medical school, because I don't think I could have given the organizing up so easily if I hadn't left the city. So I did medical school in Cleveland, and then came to Brown for residency, mostly because I had gotten married, and my wife was also a family physician or was going to residency in family medicine. And so we had to look for a residency program that was large enough that would let us both take vacations at the same time. And none of the family medicine residency programs in the Bronx at that point were that large. But Brown had a 13-person-a-year residency program, and that everybody thought was going to be big enough so that we could take vacations together. And that's what brought me to Rhode Island to begin with.
Very cool. So what do you do in Rhode Island now?
Now I do a couple of things. I spend my mornings writing fiction when there's no coronavirus pandemic, at least. In the afternoon, I see patients 2 half-days a week at a community health center. And then I spend the rest of my afternoons working with 2 mayors, the mayors of the cities of Central Falls and Pawtucket, who together are responsible for about 100,000 people. I'm the chief health strategist for the city of Central Falls and the health liaison for the city of Pawtucket. And I try to get everybody working together to build an approach to improving the health of the population by leveraging the opportunities provided us by robust primary care, but do it in a really different way. We're trying to do it so that we can provide primary care to the entire population, first of Central Falls and eventually, we hope, of Pawtucket.
So, Dr. Fine, if I can ask, you've developed a model called the Neighborhood Health Station. Could you explain what you mean by that?
Sure. A neighborhood health station is a single clinical entity that aims to take care of 90% of the population of a place and provide care in such a way as to care for 90% of the health services needs that population experiences. I have to say, by way of acknowledgement, that 90-90 setup came out of work that Larry Bauer organized, about 15 years ago, when he brought a bunch of people together to try to come up with a new model for how to do primary care. And the 90-90 piece was something that I was convinced by and spent a lot of time trying to pull together when I was both when I was in the State Department of Health and then in this subsequent life. So the aim is to provide primary care to an entire population of people, and by doing that, I take advantage of the known capability of primary care to improve the public health outcomes of a population while reducing its cost. And I see this opportunity kind of every day as we bring this single population or this population into a single place where we and then use the electronic medical record to real advantage, using the quality assurance process to make sure that everybody has the prevention they need, and then having the opportunity to basically study the population and address critical issues that the population experiences by programmatic intervention.
So, if memory serves me correct, the first neighborhood health station in Rhode Island opened, was it last September?
Well, the actual first neighborhood health station opened about 3 years ago in Scituate, Rhode Island, where I live. It's a pretty suburban/rural place. The first urban neighborhood health station opened last June in Central Falls. The Central Falls Neighborhood Health Station is much larger, 47,000 square feet, and has the capacity to take care of the entire population of the city with medical care, urgent care, dental care, mental and behavioral health care, substance use disorder treatment, lab, x-ray, physical therapy, and pharmacy, and also optometry, all in one place. And before the COVID pandemic, we were almost to having it open 8 o'clock in the morning to 8 o'clock at night every weekday. And we were within a month of opening on Saturdays, and then a couple months later would have come open on Sundays. Pandemic has changed the model of care somewhat. And I'm looking forward to the day when we go back to doing it with that kind of fairly advanced access.
So could you describe the organization within that neighborhood health station? You've got all of these groups that are used to working independently or in silos. How does it work when they're all brought together?
Just kind of works. I mean, we use a single medical record. We've completely integrated mental and behavioral health care. So we have teams of clinicians who have mental and behavioral health care as part of the team, who have community health workers as part of the team, nurse care managers, medical assistants, so that, we have clinicians seeing individuals for specific problems that those individuals encounter. But we also have people looking at the measures of how we're doing from a public health perspective, looking at all our smokers and trying to get all our smokers to quit, looking at all our diabetics, trying to work on improving control of diabetes, of hypertension, and other chronic medical problems. But it functions as a team. So, we may have somebody with a patient who's having trouble quitting smoking, and if that happens, we have, a person who works only on smoking cessation. We have access to behavioral health who can help with behavioral change. Sometimes, we will send out a community health worker to knock on a door or establish a relationship with somebody who's having difficulty with a medical problem or a mental behavioral health problem or a social problem. And together we work to solve those problems. So in addition to everything else, we run a very sophisticated, or so I would like to think, multidisciplinary team that meets once a week and together and brings together not only the usual people who are in a medical center or medical environment, but also brings together everyone involved with the provision of service to people in the community. So we have people who are mental behavioral health care folks who don't work for the neighborhood health station. We have the Autism Project. We have the local housing authority. We have EMS. We have the police and the community service unit of the police. We've had, not always as consistently as I might like, we've had probation and parole. We have the schools as part of this, so that we together, anybody can present a patient, and together we sort of sort through how we solve their problems.
So how is this funded?
Actually funded simply as a community health center. Community health centers get a different kind of funding at the end of the day than most primary care practices. They get something called cost-based reimbursement. So the basic funding just comes off, that legacy process called fee-for-service, but under this environment of cost-based reimbursement. And that extra reimbursement that community health centers get basically gives us what we need to make sure that we can get everybody taken care of in this way.
So I would imagine to bring together all of those groups that are used to being separate, is a pretty challenging kind of cultural. How do you create a culture that allows people to really take advantage of working together?
I think you just work at it and do it iteratively. I mean, everybody, the nice thing about the community health center environment is that everybody's there to take care of people in their community. They're not there to make their own profit. Everybody's salary. And I think that kind of helps the whole process because everybody's, responding to a single set of incentives, and the incentives are how good a job can we do taking care of this population? And when you pull away the incentive of competitive billing and having to chase a certain set of numbers, though we are conscious of our numbers, let me tell you. But when you take away the real obsession that being fee-for-service driven, having like your income depends on your numbers kind of world, then it's much easier to collaborate. I have nothing to offer most people with back pain, and I have nothing to offer most people with tooth pain. As far as I'm concerned, nothing makes me happier than to have somebody with a red eye go to see the optometrist without coming to see me. Nothing makes me happier than to have somebody with anxiety find their way quickly to one of my mental behavioral health colleagues. Nothing makes me happier than to have somebody with back pain see a physical therapist. And nothing makes me happier than to have somebody with tooth pain. I really have nothing to offer. Just go to see the dentist. I don't contribute anything to that. And knowing that those services are there and that we don't have to fight for them is an amazing thing. Once we got to the integration of mental behavioral health care, everybody's life improved tremendously because we had, people who were colleagues who could provide the service, work through what needed to be worked through with the people who were struggling with mental and behavioral disorders. It's, and you can do this. It's the same sort of thing for each of these different areas. And then having us function together off one electronic medical record in one physical place means, if somebody walks into the dentist with elevated blood pressure, they don't have to jump through a hoop. They just send them downstairs, and we sort of do what we need to do to take care of it. And similarly, if somebody walks in to urgent care with tooth pain, I say, well, let's just take you upstairs and get it addressed. Having the services we need in one place turns out not to be that difficult. And our cultures, our overarching culture, which is, a commitment to community and taking care of the problems real people have, we all actually do have the sense that we're all in this together and collaborate quite well without much hassle. And, it took some time to get there. There was an evolution that we had to go through around mental behavioral health in particular. There was some evolution we had to go through around dental care. There was a period in which the community health center said you can't go to the dentist until you have become a primary care patient of ours. And some of us said, let's try on any door is a good door policy. Let's not have too many rules about how to become a patient. Let's meet people where they are. And that took a lot of the pressure off, a lot of craziness out of our internal operations. Because all of a sudden we were in this together and we were there to help each other.
Dr. Fine, how did you break down those barriers for patients? Is it something that you did internally by changing the rules internally, or did you have to externally advocate for this?
Well, I think probably a little bit of each. there's always a bit of inside-outside game in any organization or institution. I think the first thing was sort of taking on mental behavioral health and integrating it. And, that unfortunately took some change in personnel because my mental behavioral health colleagues were not so ready for that. Then the dental, opening up dentistry was just making the point that we should be looking for any door to be open. And, if, it's taking a public health frame. If somebody came in because their teeth hurt and we checked their blood pressure and found their blood pressure was high and could fix their blood pressure and prevent a stroke or heart disease, everybody benefited. And everybody kind of understood that once we sort of, poked a little hole in the silo. And, then all the grain came running out together and we saw it was all grain and it was all good grain.
That's brilliant. Cool.
It was easy,
So,
actually.
Dr. Fine, can you comment on the results? I don't know if you have quantitative results or qualitative results that you can share with us.
Well, this is a bit of a work in progress, but we've had some results intermittently, like we were able to reduce adolescent pregnancy in the city of Central Falls by 55% over a couple of years. That's a big number.
That's a big number.
We were able to reduce the use of EMS by people who use EMS more than once a year by 20 to 30% over a couple of years. So that's bounced around a little bit depending on some external influences. Those are the really big things up front. I think we have not yet, we got 150 people to quit smoking, which to me was big news. And I think if we could stay at the smoking thing, we would end up with a very low rate of smoking indeed, already pretty low from the state's perspective, but we're just getting moving on this. Now, one of the other advantages around smoking was being able to work closely with the city. So the city became the first city in Rhode Island to increase the minimum age for tobacco purchase to 21. And works with us around getting smoking out of city parks. And this kind of broad collaboration involving city government as well makes us more able to achieve public health outcomes in this city that is the poorest and probably most stressed, certainly most Latino city in the state. It has given us a place to stand that's exceptional. And it's way more fun for me to be able to do some things with city government. The mayor and I have in most springs organized walks around the city, sort of from a fitness perspective. We do all sorts of wild stuff together, and it's great fun.
So what about the COVID epidemic? How has the Neighborhood Health Center responded, and how has the COVID epidemic changed the Neighborhood Health Center?
Well, I think that this pandemic has been the largest quick change in health services, I've ever seen. So we went quickly to having a clean building and a dirty building. We have a couple of different sites, and one of those sites became the place where we did routine physicals and so forth, and one of the sites became the place where we took care of anybody who was sick. We created a respiratory clinic, which is now doing testing. We basically moved almost all the care we did to the telephone instead of inpatient visits. And we've actually had to deal with a huge drop-off in volume, which has accompanied all this. And, where that drop-off in volume will lead us and every primary care practice I know of, every community health center I know of, I cannot tell you. But we adapted and adapted fast. And hopefully that will stand us in good stead over the long term.
So could you give me your sense of your neighborhood health station, its ability to keep people away from the hospital so that they don't end up overwhelming the emergency room or end up needing ICU beds?
Well, I don't think we can change the need for the number of ICU beds. As I understand this disease, I think that need is a function of disease severity alone. And that has to do with, both the viral inoculum, I suspect, that's suspected, not proven, and likely also has to do with the underlying condition of the person who gets sick, the presence of it, age and multiple medical problems puts people at far greater risk. We are pretty effective, I think, at taking care of our own patients and making sure they don't need the emergency room. And this process let that get better, because where before our systems were such that it was relatively hard to get a clinician on the phone, now we are begging for people to call us so we can help them over the phone, because that's the only way we're staying alive financially at the moment. And with the combination of a respiratory clinic and testing, that lets us take anybody who is not so sick that they need hospitalization and take care of them in their own community. And this is a particularly potent disease to do that with. There's no treatment and no vaccine. So, at the end of the day, our job is, make the diagnosis more or less, and then tell people to isolate unless they're short of breath, dehydrating, or change in mental status. Short of that, I think we're all managing everyone. And that's a good thing. It's a drop in the bucket of what we could do with other diseases and what we're learning to do. I think we're learning to do much pharyngitis over the phone without a rapid strep test. I think we're treating a little more. I think we're learning to manage urinary tract infections over the phone. All sorts of stuff that we used to make people come in for, in part because it gave us a bit of better clinical evaluation, but in part because it was people coming for a visit that served the business model. And now we just assume people didn't come in, and in order to protect everybody's health and reduce transmission, we're doing things very differently, and I think much of that will end up sticking. And so we may see a big rethink of how many exam rooms we all need and where we spend our days and how we interact with people. Certainly that's going to be necessary for, I'm guessing, 6 to 12 or even 18 months, but even after the COVID crisis passes, I think these habits are going to be, I think the culture was drifting in this direction, and these are habits that we are going to have a hard time and probably shouldn't unlearn. Our clinical judgment is getting better because we have to sort of fly by our wits, not just, sort of follow what the test said.
So, Allie, did you have another question?
I have talked to a lot of my classmates and young family physicians who are really interested in a model like this. So do you have any suggestions or words of wisdom for us who are looking to either create something like this in a community or like get on board with another organization similar to yours, because this just seems to make sense, and it's not the way that primary care is all over the place. So how do we get involved in something like this?
I think the strongest approach is to start in your own communities. Hard as medical students in residence, but this is where young faculty, I think, are critical. And you know, this is where developing relationships with people on the city council, helping people understand that this is possible and that you don't have to wait for somebody else to do it. And in fact, if you wait for somebody else to do it, they're going to do it in a way that serves themselves. So this is where, you know, pulling people together, beginning the process of community organizing itself, I think is pretty critical. I now believe, after some conversations with colleagues, that all residency programs ought to, and I don't know exactly how they all ought to fund it, but I have some thoughts about it, that all residency programs ought to have as part of their faculty somebody who's a trained community organizer who can help get this kind of thing going, community by community. And that will give their graduating residents a great place to move into. This turns out to be not that hard. It just takes, you know, some energy and some imagination, and helping people who, you know, have internalized the oppressor, who, you know, have come to believe that the way primary care looks now is the way it has to be. The opportunity is to talk about it in such a way as people can see it as an alternative and as real. And once you do that, then people get together and start to make it happen. So I think this is the challenge to your generation of people, Allie, is not to wait for somebody else to do it, but to sort of take matters into your own hands and start doing it yourself. But you're going to have to practice in these in one way or the other, and you might as well do it in a way that's exciting and fun.
Right. Thank you so much. That's great advice.
One other small piece of advice is that our colleagues are often in terror of losing their jobs. Now, I understand people have student loans, and I get that, but on the other hand, you know, I've never met a starving physician. And I think the notion that we walk around being afraid of losing our jobs is the extent to which we have internalized the oppressor. All of us, if we should lose a job, can walk across the street, get another one, and most of us are likely to be solicited to take 5 different jobs. But where we get this sense of fear, you know, I know the culture works to create it, but you know, I think it's a perfectly good time to have the courage of our own convictions, understand the value of our own science, and bring that science to the table as we talk to the communities in which we live.
So we're bringing things to a close here, Dr. Fine. Any final comments or any final insights that you'd like to share with the audience?
Only thanks to you, Larry, for having put the 90/90 group together all those years ago, and for being such a kind of driving force, helping family physicians to see the value of their own discipline. You know, it's kind of amazing to me that here we have this jewel. Here we have, you know, the kernel of how you make a healthcare system for all Americans, and that and you know, that ought to be the basis on which we organize a healthcare system that's about taking care of people and doing it in a way that's for people, not for profit. And we have not somehow developed the courage of our own convictions. But what you do is you go around and encourage us to have that courage. And that is really groundbreaking. So thank you for that.
Well, thank you very much. And that reminds me to mention that if people would like to learn more about your thinking, you've written a wonderful book called Healthcare Revolt. And that is available through your booksellers online. and sometimes elsewhere. Any comments about on the book you want to share with people?
Oh, just I'm supposed to say that sometime this week, I think, it will come out as an audiobook for the first time.